Welcome to the Deep Dive Ortho. Today we're setting our sights on something profoundly significant, something we all possess and rely on daily, yet maybe don't give that much conscious thought to: the human skeleton.
It's true.
It's really the unsung hero, isn't it? Supporting us, but also silently recording the story of vertebrate life. It's a marvel of engineering and biology just working away beneath the surface.
Absolutely. A living record in many ways.
In this deep dive, our focus is squarely on that remarkable material itself, bone. Our conversation is inspired, in part, by the extraordinary insights of Dr. Roy A. Meals, a distinguished orthopedic surgeon and author, particularly drawing from his acclaimed work, Bones, Inside and Out.
Fantastic book. Really comprehensive.
Yes, we'll journey through some surprising facts and perhaps unique perspectives on bone, from its biological wonders right through to its enduring presence in our culture and history.
Covering the whole spectrum.
And to navigate these fascinating intricacies and their profound implications for orthopedics and beyond, we are absolutely delighted to be joined by an expert with an exceptional ability to synthesize complex information into clear, actionable understanding. We're honored to welcome Prof. Mo Imam. Your extensive expertise makes you an unparalleled guide for this particular deep dive. Prof. Mo Imam, thank you. It's always a pleasure to discuss a topic so fundamental, yet, as you rightly say, often viewed rather superficially, perhaps. Dr. Meals' work certainly offers a wonderful, comprehensive lens to appreciate bone in its entirety. It reveals layers of complexity many might miss. Indeed. And our mission today is precisely that: to extract pivotal knowledge and insights about bone, aiming for a comprehensive understanding that really goes beyond the textbook. But we're aiming for those aha moments, and maybe a fresh, perhaps even profound, appreciation for this absolutely vital tissue that underpins so much of what we do in medicine. So, let's begin our exploration. Let's examine bone's fundamental nature. Prof. Mo Imam. Let's do that. Prof. Imam, it's quite extraordinary how bone, unlike many other tissues, can fully regenerate without leaving a scar. From your perspective, what's the most profound clinical implication of this unique regenerative capacity, especially for us in orthopedics? It's something perhaps we sometimes take for granted. Prof. Mo Imam, that's an excellent point to start with because it truly is remarkable. I think what's most fascinating and clinically significant about bone's regenerative capacity is that it heals by regeneration, not by repair, right? A crucial difference. Prof. Mo Imam, a crucial difference. Think of soft tissue, skin, muscle. When they're injured, they heal primarily through fibrosis, forming scar tissue.
Yes.
Prof. Mo Imam. And while that scar provides structural integrity, it often lacks the original tissue's functional properties. It might be less elastic, less strong, perhaps aesthetically altered. Bone, on the other hand, well, it restores its original architecture and its mechanical properties fully. Prof. Mo Imam, theoretically, yes. A healed fracture, given optimal conditions, can theoretically be as strong as, or even stronger than, the bone was pre-injury, which is incredible when you stop to think about it. Or Prof. Mo Imam, it is. And for us in orthopedic surgery, this changes everything about our approach to injury. We're not simply mending, we're facilitating a natural biological process. A rebirth, if you will. So our role is more about enabling that process. Prof. Mo Imam.
Exactly. Our role, whether through casting, bracing, or complex surgical fixation, is to provide the optimal environment for this intrinsic healing to occur. That means ensuring appropriate mechanical stability, not too much rigidity that inhibits callus formation, but enough to prevent excessive motion that could disrupt the delicate healing cascade. A fine balance, a very fine balance. We also have to consider the biological milieu, adequate blood supply to the fracture site, the patient's nutritional status, managing systemic conditions like diabetes or smoking.
Things which can significantly impair this regenerative potential. And when those aren't aligned, Prof. Mo Imam, well, that's when we see complications. Delayed unions, where healing takes longer than expected, or non-unions, where healing fails entirely. And these often necessitate further, sometimes quite extensive, surgical interventions. So this fundamental capacity for true regeneration, it underpins so much of our success in fracture care. It allows patients to return to full function in a way that would just be impossible with scar-forming tissues. That's a crucial distinction, the regeneration versus repair. It really does reframe our understanding. And speaking of bone's remarkable properties, beyond its obvious role as a rigid framework, Dr. Meals also touches on its immense versatility structural support, enabling movement, acting as a mineral reservoir. Can you expand on this for us, perhaps with some less intuitive examples of its multifaceted roles? Prof. Mo Imam, indeed. When you connect this with the bigger picture, bone's versatility is genuinely astonishing, far beyond just being a scaffold. Yes, it provides structural support, crucial protection for vital organs, the skull safeguarding the brain, the rib cage shielding the heart and lungs, obvious, perhaps. The basics we all learn, prof mo imam, exactly. But it's also absolutely fundamental to locomotion. The intricate articulations between bones, cushioned by cartilage, powered by muscles, they allow for an incredible range of movement, from the precise, delicate movements you might need in microsurgery to the powerful, dynamic actions of an athlete. But there's more, isn't there? The metabolic aspect. Pro imam. Yes. What's often overlooked is bone's role as a dynamic metabolic organ. It's not just a static storehouse, it's a living, breathing component of our metabolic machinery. Right. Pro imam. Bone serves as the body's primary reservoir for essential minerals, particularly calcium and phosphate. And this isn't passive storage, it's meticulously regulated. It plays a critical role in maintaining systemic mineral homeostasis, which is vital for countless physiological processes, such as Prof mo imam. Well, nerve impulse transmission, muscle contraction, blood clotting, crucial cellular signaling pathways. Bone is constantly remodeling, releasing, and absorbing minerals as needed to maintain these delicate balances. So it's constantly active. Prof mo imam. Constantly active. And furthermore, don't forget the bone marrow, nestled within the bones. That's the site of hematopoiesis, the production of all blood cells. Red blood cells, white blood cells, platelets. This makes bone a vital component of our immune system and oxygen transport too. So far from inert, it's a bustling, metabolically active tissue, constantly adapting and contributing to systemic health. It's incredible how often we, even as medical professionals, might focus on the mechanics and perhaps forget that profound metabolic dynamism. Let's delve deeper into those intricate processes. Could you walk us through the cellular and molecular mechanisms behind how bones grow, break, and then, of course, heal? Perhaps using an analogy to make those complex steps a bit more accessible. Prof mo imam, of course. Bone growth, breakage, and healing. It's a continuous, highly coordinated biological dance involving specific cell types. Let's consider growth first, especially during development. For most long bones, this happens through a process called endochondral ossification. Okay, prof mo imam. Think of it like a master builder constructing a grand edifice, but starting with a temporary, intricate scaffolding made of cartilage. Chondrocytes, the cartilage cells, they proliferate and swell up, essentially creating the initial blueprint and framework, the template, as it were, prof mo imam. Precisely. Then, almost intentionally, they undergo programmed cell death, apoptosis, leaving behind this perfectly organized matrix. This vacant, pre-structured space is then invaded by blood vessels and progenitor cells. This allows osteoblasts, our bone-building cells, to come in and lay down new bone matrix piece by intricate piece, eventually replacing the entire cartilage scaffold with robust bone. And this process continues through puberty, lengthening our bones, a remarkable construction process. And when it breaks, right, when a bone breaks, the healing process typically follows 4 overlapping phases. Think of it like a carefully orchestrated repair crew arriving on site. Immediately post-fracture, you have the inflammatory phase. A hematoma forms at the site. Inflammatory cells rush in to clear debris. That's the emergency response, signaling for the repair to begin. Step 1, clean up and alert. Prof mo imam. Exactly. Next comes the soft callus phase. Like a temporary splint, fibroblasts and chondrocytes produce fibrous tissue and cartilage, forming a sort of bridge across the fracture gap. It's not rigid yet, but it starts to stabilize the area, providing some initial stability. Prof mo imam, correct. This then transitions into the hard callus phase. Here, the osteoblasts, those industrious bone builders, deposit woven bone within that soft callus. They gradually turn the temporary splint into a more substantial bony bridge, so solidifying the structure. Prof mo imam, yes. And the final and longest phase is remodeling. Here, osteoclasts, which are the bone resorbing cells, think of them as the demolition and shaping crew, and the osteoblasts work together in concert. They replace that initial, somewhat disorganized woven bone with stronger, more organized lamellar bone, refining the repair. Prof mo imam, precisely. This process meticulously restores the original bone shape, density, and mechanical strength, often making the healed bone indistinguishable from its pre-injury state. It's really a testament to the body's incredible design. That analogy of the master builder and the repair crew really brings it to life. So it's this constant push and pull between building and breaking down, an incredible level of cellular coordination. What common factors do you see influencing these healing rates and outcomes in your practice? And how does this biological understanding guide our fracture management decisions day to day? Prof mo imam. That raises a truly important question for daily clinical practice. A multitude of factors, both local and systemic, can profoundly influence bone healing. At a systemic level, well, a patient's age is significant. Younger patients generally heal faster. Higher metabolic activity, a more robust cellular response. Makes sense. Prof. Moimam, nutritional status is paramount, adequate protein, calcium, vitamin D, other micronutrients, they are the essential building blocks. If a patient is malnourished, healing can be significantly delayed. And comorbidities, Prof. Moimam,
Yeah.
absolutely. Things like diabetes, peripheral vascular disease, chronic kidney disease, they can impair healing due to compromised cellular function, reduced blood supply, or metabolic imbalances. And of course, smoking. Smoking is a notorious detrimental factor. It impairs vascularity and directly inhibits osteoblast activity, often leads to significantly higher rates of non-union. So systemic factors are huge. What about local factors at the fracture site? Prof. Moimam. Locally, the blood supply to the fracture site is absolutely critical. Fractures in areas with a tenuous blood supply, think of the scaphoid bone in the wrist, or certain parts of the femoral head, they are inherently more prone to non-union because the essential nutrients and cells for healing simply cannot reach the area effectively. The supply line is cut off, essentially. Prof. Moimam. In essence, yes, mechanical stability is also key. While a certain degree of micromotion can actually stimulate callus formation, excessive movement at the fracture site can disrupt that delicate soft callus, prevent the transition to hard callus, leading to a failed union. So our management strategies are all about controlling that. Prof. Moimam. Whether non-operative with casting and bracing, or operative with plates, screws, intramedullary nails, they are all meticulously designed to achieve an optimal balance of stability. This allows the biological processes to proceed without undue mechanical stress. It fosters either primary healing, direct bone formation without a large callus, or secondary healing, which involves the callus formation we discussed. Understanding these biological principles is what allows us to tailor treatment plans, predict potential complications, and ultimately guide our patients towards the best possible outcome. That deep understanding truly informs every decision we make in a practical sense. Looking ahead, if we consider future possibilities, how might an even deeper understanding of bone's intrinsic ability to repair itself lead to less invasive or more effective interventions? I'm thinking about the cutting-edge genetic therapies, novel growth factors, perhaps advanced bioscaffolds. Prof. Moimam. This is indeed one of the most exciting frontiers in orthopedic research. Given bone's remarkable self-repair capacity, the future lies in either significantly augmenting this natural process or manipulating it to overcome current limitations, particularly in challenging cases, large bone defects, non-unions, or conditions with compromised healing. So, boosting nature, essentially. Prof. Moimam. Boosting nature, or perhaps guiding it more effectively. For instance, our evolving understanding of the precise signaling pathways regulating osteoblast and osteoclast activity. This opens doors for highly targeted drug therapies. Imagine medications that could upregulate specific growth factors like bone morphogenetic proteins, BMPs, potent stimulators of bone formation, or drugs that could inhibit factors detrimental to healing. Delivered locally, Prof. Moimam, ideally, yes. Delivered locally directly to the fracture site, perhaps via a biodegradable polymer that releases the growth factor over time, concentrating its effect precisely where it's needed, and minimizing systemic side effects. And genetic therapies, Prof. Moimam. Genetic therapies also hold immense promise. We might, in the future, be able to genetically engineer a patient's own cells, or cells introduced into the fracture site, to overexpress certain bone-healing proteins, thereby supercharging the natural repair process. Wow. And bioscaffolds, Prof. Moimam. Bioscaffolds are another incredibly exciting avenue. These are engineered materials, often porous, biocompatible, designed to mimic the natural extracellular matrix of bone. They can be seeded with cells, growth factors, even stem cells, providing an ideal three-dimensional environment for new bone formation. For large defects, perhaps. Prof. Moimam, exactly. For massive bone loss due to trauma or tumor resection, these scaffolds could potentially grow entirely new bone segments. This could negate the need for complex, often morbid bone grafting procedures from other parts of the patient's body. That would be transformative. Prof. Moimam, it really would. This could lead to a future where we move beyond simply stabilizing fractures to actively enhancing the speed and quality of healing in a truly sophisticated, biologically potent manner. Potentially reducing hospital stays, improving long-term functional outcomes, preventing chronic complications like persistent non-unions. It's about leveraging the body's own healing potential to its absolute maximum. The potential there is truly immense, almost bordering on science fiction, yet grounded in such rigorous biological understanding. Let's transition now to the transformative impact of medical innovations in orthopedics. Dr. Mills' work often references the spectrum from the very first X-rays to the advanced surgical techniques we employ today. Can you trace that historical significance for us? Highlight how these innovations have fundamentally reshaped diagnosis and treatment planning in our field. Prof. Moimam. Historically, the advent of X-rays, Well, it was nothing short of a revolution in medicine, certainly comparable to the discovery of antibiotics or anesthesia, a complete paradigm shift. Prof. Mo Imam, absolutely. Before Wilhelm Röntgen's discovery in 1895, diagnosing a fracture was largely a process of deduction, wasn't it? Palpation, observing deformity, assessing swelling, relying on patient symptoms. It was often a clinical best guess, sometimes leading to inaccurate reductions or misdiagnoses. You can imagine the uncertainty. Prof. Mo Imam. Tremendous uncertainty. X-rays immediately provided a non-invasive visual window into the skeletal system. For the first time, we could accurately visualize fractures, pinpoint dislocations, identify bone pathologies. This transformed diagnosis from an empirical art into a more scientific, verifiable discipline. Imagine the relief for both patients and surgeons. It enabled precise localization, characterization of injuries, which in turn allowed for far more accurate reduction and fixation, significantly improving patient outcomes. And fast forward to today, beyond basic x-rays, Prof. Mo Imam. Well, fast forward to today, and we've seen an explosion of advancements. Techniques like CT scans provide detailed 3D reconstructions. These are invaluable for assessing complex intra-articular fractures where the fracture extends into a joint surface, or for meticulous preoperative planning in procedures like total joint replacements, seeing it in 3 dimensions. Prof. Mo Imam. Exactly. A CT scan essentially takes multiple X-ray images from different angles and uses computer processing to create cross-sectional slices, and then a 3-dimensional model. This lets us see bone fragments in a way a 2D X-ray simply cannot. Then there's MRI, magnetic resonance imaging. This offers unparalleled soft tissue visualization, crucial for diagnosing ligamentous injuries, meniscal tears, disc pathologies in the spine. Different technology, different strengths. Prof. Mo Imam. Completely. Unlike X-rays or CT, MRI uses strong magnetic fields and radio waves. It's excellent for showing structures like cartilage, tendons, muscles, nerves. These leaps in imaging have allowed us to understand pathology with a precision that was unimaginable even a few decades ago. So from 2-dimensional shadows to incredibly detailed anatomical maps giving us unprecedented clarity, how have these imaging leaps then directly translated into the advanced surgical techniques we employ today, fundamentally improving patient care? Prof. Mo Imam. Indeed. The clearer the image, the more precise and effective our interventions can become. Advanced imaging has directly paved the way for many of the sophisticated surgical techniques that are now standard practice. Consider total joint arthroplasty. Detailed preoperative planning using templates derived from high-quality X-rays and CT scans allows for incredibly precise implant sizing and positioning. That's absolutely critical for the long-term success and longevity of a knee or hip replacement. Getting it right first time. Prof. Mo Imam. Exactly. We can predict joint mechanics and alignment with a degree of accuracy that significantly reduces revision rates. Minimally invasive surgical techniques like arthroscopy for joint repairs rely heavily on accurate imaging to guide instruments through small incisions. Keyhole surgery. Prof. Mo Imam. Precisely. For example, repairing a torn anterior cruciate ligament, ACL, in the knee via arthroscopy. That's only possible because we can accurately visualize the joint space and the torn ligament on an MRI, and then navigate our instruments using optical imaging and precise anatomical landmarks. This approach significantly reduces patient morbidity, decreases recovery times, often leads to less postoperative pain and scarring, and complex reconstructions. Prof. Mo Imam. Complex reconstructive surgeries, for instance, in severe trauma with comminuted fractures or following tumor resection. These are now achievable with unprecedented precision due to our ability to pre-plan the entire procedure with 3D models derived from CT data. We can virtually perform osteotomies, plan precise bone graft harvesting, accurately place fixation hardware before even making an incision, virtual surgery beforehand. Prof. Mo Imam. In effect, yes. This precision ultimately leads to dramatically improved patient outcomes, allows for shorter hospital stays, and has expanded treatment options that were simply unimaginable a century ago. It's a compelling testament to how diagnostic innovation directly fuels therapeutic advancement, allowing us to restore function and improve lives in ways that were once considered miraculous. It's astonishing how far we've come. Yet Dr. Mills, and indeed many observations from within our field, touch upon a critical paradox of advanced imaging. He notes that sophisticated scans like CT and MRI can sometimes lead to anxiety when features that don't look quite right are found, findings that perhaps, in retrospect, should have remained unidentified or ignored. Prof. Imam, this is a key and very practical challenge for medical professionals. Can you delve into the concept of incidentallomas and the clinical dilemma of interpreting findings that may not be clinically significant but cause significant patient distress? Prof. Mo Imam. Yes, this is a challenge we encounter almost daily in orthopedic practice, and it raises a profound clinical and ethical consideration. The term incidentalloma. It refers to an unexpected, often asymptomatic lesion or finding discovered incidentally during imaging performed for an entirely different reason. Found by chance. Brahma. Exactly. With increasing sensitivity and widespread use of advanced imaging like CT and MRI, we are finding more and more of these. For example, a patient might have an MRI for knee pain, and an incidental disc bulge in the lumbar spine unrelated to their knee is noted on the scan. Or a CT scan for abdominal pain might pick up a tiny asymptomatic osteochondroma on a rib. Things that weren't being looked for. Prof. Mo-Imam.
Yeah.
Precisely. And the clinical dilemma here is significant. On one hand, as clinicians, we have a duty to investigate and rule out serious pathology. We can't simply ignore a potential finding. On the other hand, many incidental findings, particularly in the musculoskeletal system, things like degenerative changes in the spine without back pain, minor meniscal tears in a pain-free knee, small areas of bone marrow edema, they are incredibly common in the general asymptomatic population, very common. Prof. Mo-Imam, very common. Yet once these findings are identified, and more importantly, communicated to the patient, they can provoke significant anxiety. Patients often interpret an abnormal finding on a scan as the definitive source of their problem, even if their symptoms don't correlate. Or they may worry about future pain or disability, which can lead down a rabbit hole. Prof. Mo-Imam, it can. It can lead to further, often unnecessary investigations, sometimes even inappropriate interventions, contributing to what's known as overdiagnosis and overtreatment within the healthcare system, not to mention the psychological burden on the patient. So it's about managing not just the imaging finding, but the patient's reaction to it, which can sometimes be more challenging than the pathology itself. How do we, as orthopedic surgeons, balance the immense benefits of detailed imaging with this potential for overdiagnosis or patient anxiety? What frameworks do you use for managing this, and how does clinical judgment play such a crucial role in shaping current practice guidelines in this area? Prof. Mo-Imam. It absolutely is about managing the patient's perception and anxiety. This requires a really nuanced approach and places a strong emphasis on experienced clinical judgment. Our first framework is always to prioritize the patient's clinical presentation. The patient first, not the scan. Prof. Mo-Imam, exactly. Does the imaging finding genuinely correlate with their symptoms, their physical examination findings, their functional limitations? For example, if a patient has severe knee pain, but their MRI shows only minor degenerative changes and a completely asymptomatic disc bulge in their lumbar spine, well, the tongue bulge is likely an incidental finding not relevant to their current knee problem. If there's a significant discrepancy between symptoms and imaging, the imaging finding, no matter how abnormal it appears in isolation, might not be the cause of their current issue. Correlation is key. Prof. Mo-Imam. Correlation is absolutely key. Secondly, clear, empathetic, and patient-centered communication is paramount. We need to explain findings in a way that is understandable, honest, and crucially, reassuring where appropriate. For an incidental finding, explaining its prevalence in asymptomatic individuals, its natural history that many such findings never cause problems, and the low likelihood of it causing future issues, that can significantly alleviate anxiety. Providing context. Prof. Mo-Imam. Providing context. It's about educating the patient to shift their focus from the potentially alarming image to their actual functional status, their symptoms, their overall well-being. We empower them with context. And the ethical side, over-investigation. Prof. Mo-Imam. The ethical considerations of over-investigation are indeed central here. Every additional scan, every biopsy, every specialist referral carries risks, radiation exposure, potential complications from invasive procedures, significant financial burden on the patient and the healthcare system, and profound psychological distress. Clinical judgment, honed through years of practice, allows us to critically appraise imaging reports in the broader context of the patient's overall health and the likelihood of a finding being clinically significant. It's about discerning what's relevant from what's merely present. The art of medicine, really. Prof. Mo-Imam. Very much so. And current practice guidelines increasingly incorporate this awareness, advocating for judicious use of imaging, especially in asymptomatic individuals or for conditions where clinical assessment is sufficient. For example, for nonspecific lower back pain, guidelines often recommend deferring imaging in the absence of red flag signs of serious underlying pathology, precisely to avoid identifying common incidental findings that do not alter management but create unnecessary anxiety. It's a constant dance between the precision offered by cutting-edge technology and the art of medicine, guided by that fundamental principle of do no harm. That's incredibly insightful, and it's a profound challenge that I think resonates across various medical specialties. Now let's shift our perspective entirely and look at bone beyond the living body. Dr. Meals dedicates a fascinating portion of his work to bone's enduring presence outside us, as fossils, in ossuaries, as tools, even musical instruments. He also acknowledges its pervasive influence in history, religion, and idiom. Prof. Imam, how does this broader, almost anthropological perspective enrich a medical professional's understanding of bone? Prof. Mo Imam. This section of Dr. Meal's book truly does expand our horizons. It deepens our appreciation for bone far beyond its clinical function. For a medical professional, understanding bone's presence beyond the clinical setting offers a richer, more holistic context that can even subtly inform our daily practice. How so? Prof. Mo Imam. Well, for instance, consider paleontology and archaeology. Studies of fossils don't just tell us about ancient life or extinct species, they critically inform our understanding of skeletal evolution, adaptation, and pathology across millennia. Examining the bones of early hominids or Neanderthals can reveal historical patterns of injury, specific types of fractures, signs of infectious diseases, or even evidence of nutritional deficiencies that afflicted our ancestors. A deep historical record, Prof. Mo Imam. Exactly. This provides insights into how skeletal structures have evolved to withstand specific environmental stresses or how certain pathologies have manifested over vast timescales. A fascinating example might be studying joint loading in bipedal hominids. This can offer clues about the evolutionary pressures that shaped our hips and knees, and perhaps even hint at the origins of common modern conditions like osteoarthritis, connecting past to present pathology. Prof. Mo Imam, precisely. This deep historical perspective can help us contextualize modern orthopedic conditions, showing how certain anatomical variations or susceptibilities to injury might have ancient roots, or how human activity has impacted our musculoskeletal health over time, and the cultural uses, tools, objects. Prof. Mo Imam. Furthermore, the historical and cultural use of bone in human endeavors is profound. From ancient tools and weapons, think of bone awls, harpoons, even rudimentary surgical instruments from millennia ago, which demonstrated early humans' intuitive understanding of bone strength, durability, and workability. Ingenuity, Prof. Mo Imam, to architectural elements, ceremonial objects, or even artistic expressions in various cultures. Consider the elaborate ossuaries and catacombs found in parts of Europe, reflecting centuries-old cultural attitudes towards death, remembrance, and the enduring human form. These examples underscore that bone isn't just a biological structure to be fixed or analyzed, it's a material with deep cultural and historical significance, reflecting human ingenuity, belief systems, and our enduring, often symbolic connection to our physical form even after death. It truly makes bone a bridge between our biological selves and our cultural identities. It's remarkable how a seemingly simple biological structure can carry such immense cultural and historical weight, and that leads us perfectly into its enduring presence in language. Dr. Meals explores the allusions to bone in common idioms and expressions, highlighting its deeply ingrained presence in human language and thought. Why do you think bone, as such a fundamental structure, has permeated so many aspects of human expression, often in quite subtle ways? From Mo Imam. This is truly where Dr. Meals' inside and out approach shines its brightest, I think. Bone is, quite literally, our innermost framework, the very bones or skeleton of our being. It's the resilient structure that gives us shape and support, and often the last part of us to decompose, leaving a lasting record of our existence. So, it's perhaps not surprising that it has permeated human language and thought so profoundly. It represents something fundamental. Prof. Mo Imam. Exactly. Idioms like bone tired, or to have a bone to pick with someone, or feeling it in your bones. They reflect our intuitive understanding of bone as representing the core essence, durability, the fundamental nature of things. The bare bones refers to the absolute essentials, doesn't it? While to make no bones about it implies directness, honesty, speaking the unvarnished truth, it's woven into how we express core concepts. Prof. Mo Imam, it really is. Culturally, bone often represents strength, foundation, the enduring self, or even a deep primal connection. Think of the phrase bone of my bone and flesh of my flesh, found in ancient texts, signifying an unbreakable fundamental kinship. This omnipresence in language underscores that bone isn't merely a clinical entity to be diagnosed, fixed, or analyzed. It's a deep-seated cultural touchstone, a metaphor for strength, truth, resilience, fundamental existence. It's part of our collective human consciousness. And understanding that broadens our view. Prof. Mo Imam, I believe so. Understanding bone comprehensively, as Dr. Meals encourages us to do, truly requires looking beyond its purely clinical function and appreciating its multifaceted role in human history, culture, and even our everyday expressions. As medical professionals, this can even help us connect with our patients on a deeper level, as they too often have an intuitive understanding of what bone represents in a broader sense, beyond just a clinical structure. That's a truly insightful perspective, reminding us of the humanistic side of our practice and the shared understanding we build upon. And speaking of practice, let's turn to the allure of orthopedics itself. Dr. Meals highlights what he calls the charm of orthopedics, specifically noting its goal-directed teamwork, beautiful skeletal anatomy, and generally successful outcomes. Prof. Imam, from your extensive experience, what makes orthopedics such a uniquely rewarding specialty for practitioners like us, perhaps beyond what might be immediately apparent to an outsider? Prof. Mo Imam. What's fascinating here is that the charm of orthopedics, it resonates deeply with many of us who choose this path. For me, it largely stems from the tangible, often dramatic results we can achieve, and the very clear, definable objectives we work towards. That sense of making a direct difference. Prof. Mo Imam. Absolutely. When a patient comes in with a debilitating fracture, say a complex tibial plateau fracture, or with severe life-limiting degenerative arthritis that has robbed them of their mobility and independence, our goal is clear: restore function, alleviate pain, significantly improve their quality of life. The satisfaction of seeing a patient walk again without pain after a total hip replacement, or regain full use of their hand after complex reconstructive surgery following trauma, it's immensely rewarding. A tangible impact, Prof. Moimam. A tangible impact on a patient's daily life, which is profoundly gratifying. The beautiful skeletal anatomy aspect isn't just about aesthetics either. It's about the elegant engineering of the human body. The precise way bones articulate at joints, the intricate levers and pulleys formed by muscles and tendons working in perfect synchrony. It's a marvel of biomechanics and evolutionary design. Functional beauty, Prof. Moimam. Functional beauty, exactly. For an orthopedic surgeon, understanding and appreciating this functional anatomy, not just its form but its dynamic purpose, is absolutely key to successful intervention. We are, in a very real sense, structural and biomechanical engineers of the human body, striving to restore its exquisite natural balance. And the teamwork aspect, Prof. Mo Imam. And the goal-directed teamwork is absolutely vital. Orthopedic surgery is rarely, if ever, a solo endeavor. It involves the entire surgical ecosystem, the anesthetists ensuring patient safety, the nurses meticulously preparing the theater and instruments, the scrub technicians anticipating every move, the physiotherapists guiding postoperative rehabilitation, and indeed the patient themselves as an active participant in their recovery, everyone playing their part. Prof. Mo Imam. Everyone plays a critical, coordinated role in achieving the desired outcome. For example, in a complex spinal trauma case, the precise coordination from initial assessment in the emergency department through diagnostic imaging, meticulous preoperative planning, the choreography in the operating theater with navigation systems, and then long-term post-operative rehabilitation all contribute to a successful outcome that allows the patient to regain function and independence. This collaborative environment, working towards a common, often life-changing goal for the patient, is a deeply satisfying and unique aspect of the specialty. It truly is a collaborative effort, and the results can be so transformative, fundamentally changing lives. Finally, let's talk a bit more about the authority behind the insights we've been discussing. Dr. Roy A. Meals. You've worked alongside some of the field's giants. When you consider Dr. Roy Meals' background, his 40 years in hand surgery practice, his extensive research and teaching, his presidency of the American Society for Surgery of the Hand, and his 5-year term as editor-in-chief of the Journal of Hand Surgery, what, in your view, truly sets his perspective apart? What imbues bones, inside and out, with such unique authority beyond just academic rigor? Prof. Mo Imam, that's an excellent question, because Dr. Meals is, without question, a highly respected and almost iconic figure within orthopedics, particularly in hand surgery. His 4 decades of clinical practice, that's not just a measure of time, it represents an extraordinary breadth of experience. He has seen and managed an immense variety of conditions, from the most common to the exceptionally rare, across countless patient presentations and their long-term outcomes. That depth of clinical wisdom, Prof. Mo Imam, exactly. This vast clinical wisdom isn't just about technical skill, it's about accumulated insight. The ability to recognize subtle patterns, predict natural histories, and deeply understand the human element of orthopedic care. And his leadership roles, Prof. Mo Imam. His leadership roles further elevate his standing as an authority. To serve as president of the American Society for Surgery of the Hand means he was at the forefront of shaping the clinical standards and professional development for an entire subspecialty. And his extensive tenure as editor-in-chief of the Journal of Hand Surgery for 5 years, that's particularly telling. Why specifically, Prof. Mo Imam? Well, that role requires an individual to be at the absolute cutting edge of scientific and clinical advancements, to critically evaluate and synthesize countless research papers and clinical reports, and to make judgments on what constitutes valuable and credible knowledge for the field. It means he has a profound understanding of not only what we know, but also the nuances of how we know it, a critical gatekeeper of knowledge. Prof. Mo Imam. In many ways, yes. So when someone with this depth of hands-on clinical experience and this level of intellectual engagement with the scientific discourse writes a book like Bones, Inside and Out, it's not simply an academic exercise. It's distilled knowledge from a lifetime of practice, teaching, and rigorous critical thinking, bringing it all together. Prof. Mo Imam. Exactly. His ability to translate such complex scientific and clinical information into an approachable, engaging, and often entertaining narrative, as noted by reviewers, makes the book an invaluable resource, not just for orthopedic specialists, but for all medical professionals. He bridges that gap between the highly technical and the broadly accessible, offering unique perspectives that only someone with his profound depth of experience and critical understanding could really provide. It's what makes his insights feel so authentic and authoritative. And that truly speaks to why his book, and indeed discussions like this one, are so valuable. It's that unique blend of scientific rigor and engaging storytelling, providing knowledge that is, as he puts it, critical to daily life and taken entirely for granted as long as it works, yet presented in a way that avoids feeling like an audio textbook. It really helps our listeners gain knowledge quickly but thoroughly, providing those aha moments we aim for. Prof. Mo Imam. Precisely. It's about making the fundamental fascinating and the complex understandable, connecting the dots in new and insightful ways, and what an illuminating deep dive it's been. We've journeyed through the remarkable biological properties of bone, explored the transformative impact of medical innovations that have redefined our field, critically considered the nuanced challenges of advanced imaging and patient care, and finally, appreciated bone's rich cultural tapestry and its enduring presence in human thought and language. Prof. Mo Imam. Quite a journey. It's clear that understanding bone is so much more than just anatomy. It's about history, culture, and the very essence of the patient experience. Prof. Imam, thank you so much for guiding us through this incredibly insightful discussion. Your expertise has truly brought the subject to life. Prof. Mo Imam.
My pleasure entirely. It's a topic that truly continues to offer new insights with every exploration. So a final thought to leave our listeners with. As we continue to advance our understanding of bone right down to the molecular level, how might our very perception of health and longevity be reshaped by this foundational tissue? What new frontiers in orthopedics will emerge from even deeper dives into the intricate world within our bones? We encourage you to consider the multifaceted nature of bone in your own practice and thinking.
If you found this deep dive valuable, please do consider rating and sharing it with colleagues who might also appreciate a fresh perspective. Thank you for joining us on the Deep Dive Ortho. Until next time, keep exploring.